Good afternoon, everyone. We're just allowing people to come in. We've got a large number of people, so I'm just going to give it a minute or two while people come in. I think it's one of the most in-demand webinars that we've run, certainly the most in demand for 2021. So that's good. We'll just let the people come in first before we start.
Just going to open a door. Sorry, it'll be 2 seconds.
People still coming in. We'll start in a minute. It is the ACSA webinar on a COVID-19 vaccination update for everyone. And perhaps I'll ask the presenters just while we're waiting, if you're not speaking, to leave your camera on, but please put yourself on mute. People are still coming in, but the number seems to be steadying, so we might kick off. So firstly, can I welcome everyone here? I'd like to firstly begin by acknowledging the traditional owners of the lands and the many lands on which we're meeting today, and pay my respects to their elders past, present and emerging, and also to acknowledge any Aboriginal and Torres Strait Islander people who are with us in the webinar today. This is a really important topic. It's one of the ones that we've got the most questions coming about at the moment, the most interest, the most concern, the most desire to understand, which is why we decided to call a webinar really quickly. Really happy, and I'll introduce our speakers in a moment, that we've got both a medical perspective. I'll be speaking in terms of some of the conversations we've been having with government. We've also got a legal perspective, which I know is concerning many members at the moment. In terms of this being a webinar, we will be able to, we'll try and answer as many questions as we can. Some we're going to have to take on notice. So please, down the bottom of your screen, you'll see two little chat boxes, and that's the Q&A box. If you've got a question, can you please use the Q&A box? It just helps us to manage the questions, and we'll have a Q&A time at the end of the presentation. And we'll work through them, and as I said, some will be able to answer and some will need to take on notice and come back to you following today. You can use the chat if you've got comments, but if we ask you to use the Q&A for questions, chat for any comments that you want to make. The session is being recorded, so if you want to go back and listen to some of the information again, or if you need to share it, you'll be able to do that. If you do have any issues at all through the event, send us a message on the chat function and someone will be able to assist you, and we'll try and assist you as soon as we can. Without any further ado, I know people are still coming in, but there is a lot of information to get through. We're going to get started. What I wanted to do first up is just to give you maybe I'll introduce our speakers. So we've got Chris Moore, who's the board director and I think the vice president or deputy president of the Australian Medical Association, who's agreed to come along today. He's well known to many of our South Australian members. I was talking to someone the other day and they all said they knew Dr. Moore and what a great job he does. He's a full-time GP working at a large group practice in Parkside. He's the president of the South Australian AMA, as well as the chair of the Federal AMA Ethics and Medico-Legal Committee. He graduated from the University of Adelaide in 1991 and he's been in GP for 25 years, doesn't look old enough. He is an active GP in aged care, and we thank him for that because a lot of GPs no longer do that. So it's terrific, but his interests include aged care, palliative care and health, IT and communication systems. He was a former member of the Independent Advisory Committee to the Minister of Health regarding the Patient-Controlled Electronic Health Record and the My Health Record Operations Management Committee, and he's currently a clinical reference lead for the Australian Digital Health Agency and a member of its Privacy and Security Advisory Committee, so really well briefed across a number of those areas. Our other presenter today is Libby Pallo, Principal of Russell Kennedy Lawyers, and Russell Kennedy are, of course, ACSA's legal national partner. Libby's the head of Russell Kennedy's workplace relations, so she's not necessarily an expert in aged care, but she's been liaising with Anita Courtney, who is, but what we thought was really important today was to look at the workplace, the ER, and the sort of the legal issues around that. So she's the head of workplace relations, employment and safety practice, and a partner of the firm. She's worked at Russell Kennedy for over 20 years. She's a really experienced practitioner in the area of employment law and industrial relations. She's got vast experience, and she concentrates on providing advice concerning performance and disciplinary actions in all matters involving the workplace, including contractors, human resource policies and manuals, and contractors is going to be an important one for us to talk about today. She regularly presents as an expert on employment law and industrial relations to numerous sectors. She was recognised by the Best Lawyers 2014-2021 for experience in employees benefit laws and occupational health and safety law. So we've got a real expert with us in the room today. Now, to kick things off and to sort of set the scene, last week I sat in on a meeting, and a number of peaks did, with Minister Hunt, who gave us a bit of an overview of the rollout of the vaccination. So I'm going to give you a little bit of that, and then we'll get Chris to talk about the vaccinations and some of the issues coming from the AMA's point of view. So the Minister started and just advised us that pending the conclusion of TGA testing and all of those things, the rollout will commence in the second half of February. All aged care staff and residents in aged care and in disability are the highest priority. They're Group 1A, and they will receive the Pfizer vaccine, as that will be the first approved and available. Now, some of you will have seen over the weekend the reports of, it was 33 people in Norway out of 40,000 people who'd been immunised, who unfortunately over the age of 75 who passed away. I know Chris will cover this, but the reports in the media today is that it doesn't seem to be linked, but obviously that's something that is the government has rightly asked the TGA to look at quite closely and provide advice on. The way that the vaccinations will be rolled out is that government's going to contract in-reach services who are going to come into the facilities to vaccinate staff and the residents. All facilities will be covered, and there'll be a sequencing which is still being worked on. So some of the logistics, we don't have the answers for you today. Some of those logistics are still being worked on. I should say one of the first questions we asked at the meeting was whether home care staff and clients were going to be picked up. The Minister affirmed that they will. So residential aged care is in Group 1A, and we understand that home care clients and residents will be in Group 1B. Residential care will be the Pfizer vaccine. Group 1B will be the AstraZeneca vaccine. The big topic of discussion, and I know it's something that people will want to talk about today, is whether or not vaccinations would be mandated as a workplace requirement. The Minister's response to that, and obviously ACSA and pretty much everyone across the sector is saying that that's what we want to see happen. The Minister said that at this stage that's an open question that needs to be determined scientifically, and it's going to be considered by the AHPPC. He also said that he had met with the unions the day before, and they were constructive. They didn't rule that out as being a mandatory workplace requirement. Their plea, as would ours be, is that there's a uniform approach, at least at state level. We would want to see it nationally, but at least at state level, rather than it being a facility by facility decision. So I think the government has had a strong message that the sector of support for it is there, including from the unions. The AHPPC advice is likely to be available at the end of the month. And some of the other things that are being considered as part of that is the flu vaccination, whether that will be a mandated workplace requirement again, as it has been. Also the timing, there are issues getting the timing right in terms of when you have your flu vaccination and when you have your COVID vaccination. And in some instances, there's a couple of doses of the COVID vaccination. So some of that timing and logistics is still being worked through. The Pfizer, all the vaccines will be free, so people will be immunised for free. Pfizer's the one that will be provided through the in-reach service. If an individual particularly wanted a different vaccine, they would be able to get it free, but they would have to organise that separately. So if you're being immunised by the in-reach service, it'll be Pfizer. The Commonwealth's leading, managing and coordinating the vaccinations for aged care. Obviously, all of the states will have a role to play and have decisions, and I know that South Australian members met yesterday with the South Australian Department. The Commonwealth, though, is also coordinating with primary healthcare networks, which is what happened last year with the flu vaccination. So they're onto that a bit earlier. In terms of some of the other areas that were covered, we talked in the meeting about how critical communication was going to be, that there needs to be, you know, fact sheets for residents, for families, for staff. They need to be in different languages and different formats for people who've got different communications. They've undertaken to do some drafts and to give those to us for comment. And the Minister was really clear about the important role that you would play as providers in terms of making sure people have a hold of that, as well as what the government might do. There was questions about what if the InReach service has been in and we get residents who've come in after that, or we employ a staff member who's come in after that, what will happen? The Minister was clear that post that they will have access as soon as they can, but it may be through a GP or a different service. There will be a dedicated contact point or number for providers to call, as well as for people generally. We raised the issue of consent forms, and Chris and I were having a chat about that before, and I know he'll have some comments to make on that. But we did raise that this is going to be really difficult in terms of logistics and timing, and that we need to make sure that guardians and advocacy bodies are aware that it's coming, and that there's as much communication as possible to try and streamline for residents who've got cognitive impairment or someone else who's making decisions for them, that we need to prime that and make sure that it can happen so that we get the sequencing right. They are also considering requirements for visitors, and that again will be a medical assessment through the AHPPC. And we also raised the issue of people who are volunteers, partners in care, and similarly, we didn't raise it at the meeting, but subsequently, what about the allied health staff, etc., who are coming in and contractors who come in? So all of those things have been logged, just making sure I haven't missed anything here. Now, I know Chris is going to speak about this, but the Minister was also clear that the evidence around the vaccinations is that it's about lessening the impact or giving you a lower dose of COVID-19. There's not yet the evidence to say that it's going to prevent transmission, but I'm going to let the experts speak to that. So the clear thing that that we all have to get our heads around, I think, is that while the vaccination will happen, we're still going to have to really keep up and focus on all of those other COVID safe practices that are adopted around infection control, social distancing. All of those things are going to continue to be important, even with the vaccine rolling out. So that's a very potted version of the meeting. It was a good and constructive meeting. The Minister was really listening to the comments that we were making. They've said that they will come out to us with drafts of material. They know how important it is, and that we're all waiting for that, and for it to be successful we need to move as quickly as possible. So that's the briefing that we had from the Minister. There'll be many questions you asked today that there won't be an answer to, that I won't have, but that we'll be able to take them up. All of your questions will be taken down, and we'll come back to you on those that we haven't been able to clear up today. So I hope that gives people a bit of a feel for what the government's planning. But I'm going to hand over to Chris now, who's going to talk about the vaccines. And I know he's got a really interesting information to share. So I'm going to hand over to Chris. Take it away, Chris.
Thanks so much, Pat. Look, I might just give you, if you don't mind, start off with a really potted tour of what the vaccines are, because I think in the first instance, it's kind of nice to start from basics, and then look, later we'll deal with questions if you don't mind. So I'm going to do a bit of a share screen, and I'm going to go to there, and we're going to share, and then we're going to start So the first thing was just to talk about the various vaccines that are available, which you may have heard about. Now, I just want to talk to you about this. Essentially, so the whole point of the vaccines is to try and produce an immune response. Now, people talk about immune response. Normally what happens is you get a bit of the virus or something that looks like the virus into you. Your body actually thinks it's a foreign body, produces antibodies, which are proteins to neutralize that. And then later, if the virus comes in, it can attack that. The immune response is a combination of the antibodies, but other parts of the immune system, such as T cells and other cells as well. Now, there are essentially 4 types of vaccines that are available, 4 groups of vaccines. Now, I'll run through them. Now, on the slide here, you'll see in this bottom left corner is this virus, left corner is virus vaccines. These are essentially viruses which you've actually either weakened or you've banged and damaged them so much they're no longer active. Now, one of these is the Sinovac vaccine, which is made in China at the moment. And so they're injected, your body sees this, creates antibodies to it. So next time, if the live vaccine virus comes into your body, then it will be able to attack it and destroy it. The second, and I'll get on to the next slide. Sorry, my apologies. Can I move? Yeah. So the next type of vaccine is the in the top corner, in the top bit there, the ones you may have heard. These are the DNA or RNA vaccines. So DNA vaccines have been around for the last 2 decades, and mRNA vaccines, which you may have heard. Now, the two that are most notable are the Pfizer vaccine and the Moderna vaccine. Essentially what these are is they can essentially print some genetic code called RNA, that's the Moderna and the Pfizer, and they print these, which are essentially the instructions for printing part of the virus. In this case, the spike protein on the virus, the outside of the virus, which actually attaches to cells. What happens with this is this is very new technology in use for vaccines, but has, as I said, been used in veterinary areas and also in tumor therapy in the past. But essentially what they do is that they write out these instructions in a genetic code. They put it in some sort of chemical, which then is injected into your arm. It goes into your cells, into your arm, and gets your own cells to set off the 3D printers to print off part of the virus. In this case, the spike protein. The spike protein goes into your bloodstream. Your body realizes that it's a foreign body, attacks it, and then develops antibodies against it. So if you get the virus in the future, you can kill it. In the bottom bit here, the viral vector vaccines, this is the AstraZeneca vaccines. Now, essentially what they do there is we attach the genetic instructions to create part of the virus, but attach it to and piggyback it onto a virus, which can get it into your cells more easily. Now, the AstraZeneca vaccine is attached to a thing called a chimpanzee adenovirus, which can produce like cold type symptoms, but they've basically stopped it, inactivated it. They've attached this, again, the instructions for your cells to make this part of the COVID-19 virus. You inject it into your body, the virus gets into your cells and again sets off the printers to start creating part of the spike protein, and again off you go. Your body develops an immune response to that and hopefully develop immunity. So far we've dealt with the Pfizer, the Moderna and AstraZeneca. The final bit is, this is the more old type technology, which is the protein-based vaccines. Now, in Australia, we've actually had one, which unfortunately has now been put to one side, which is the Queensland University one, but also the one which you may have heard of called the Novavax. In these sort of cases, old technology, we actually develop the protein, which looks like part of the virus, and inject that in, and your body develops an immune response to that. Now, we've had lots of vaccines like this in the past, and it's the most classical type of vaccine. The only problem with it is that it takes longer to develop, and that's why these are a little bit behind in terms of development. So yeah, I thought it'd be useful to actually just start off with the various vaccines and just a little bit about them. So Sky, do you mind just getting me off share, and then I'll have a bit of a chat about what we know and what we don't know. So I just want to talk about what we actually can confirm about these vaccines. The first is they look very safe, and I'll go through some of the theoretical issues with them, but they do look extremely safe. The second thing is, and again, Pat brought this up, the one certainty about them is that the AstraZeneca, Pfizer and Moderna, what they are very good at, and they're all essentially what we think equally good at, is they stop you getting very severely ill, ending up in hospital and dying. That's their main thing that we're certain about. What we are less certain about is how long they last for and how they vary over time in terms of their ability to maintain your immunity. Whether they can stop asymptomatic infection, that means whether you can catch it at all and still, so we don't know that. And whether you can transmit the virus even if you've had the vaccination in the past. Which brings forth the issue about this debate you may have heard last week about this whole herd immunity thing and vaccinating everybody in the community to stop it transmitting through the community. Well, there's been a debate because there was a bit of a debate about the numbers. You may have heard these efficacy numbers about the various vaccines. So the Pfizer vaccine looks as though on efficacy, that at about 7 to 8 weeks, it's about 95% efficacy. And the AstraZeneca looks like it's only about 60, 70, 80% efficacy, which seems dramatically less. What I have to clarify is, first up, compared to the flu vaccine, the efficacy is about 45%. So let's put it in comparison. The next thing is that the efficacy levels are purely an issue about whether you develop enough symptoms to bother to go get a test. So they don't indicate how severe the illness is. So the Pfizer, based on these early numbers, look as though it's good at stopping you getting, a cold, runny nose, sore throat. But but it's not really a measure of whether they stop you getting severely ill. And as I said, there's no evidence that there's clear evidence that they stop transmission at this moment in time, although we hope to get data about that in the future. So therefore, all the decisions at the moment, and we went to a meeting last week, and the AMA forced this meeting to a great degree because we were very concerned about the lack of information about this. The government's policy is to make decisions about what we know, which is that it stops people getting sick and dying and ending up in hospital, which is really a very good aim, but not to overreach and try to go for this herd immunity at this stage, although it is a long-term aim, because we don't have evidence for that the vaccines can do that, because we don't know whether they can stop you passing it on. The other thing is that at the moment, none of the vaccines are approved for anybody under 16. So it's not possible to vaccinate the entire population. So the herd immunity thing is a little bit out the window at the moment, right? Now, just a few things. So Australia is going through a long process of approval because we've got time. And we believe that trust of the vaccines is extremely important. And Australia is going through the whole process like we would for any other vaccine, and we've been having lots of talks with the Therapeutic Goods Administration. And essentially what they do, normally it takes about 9 months to approve vaccine, but what they've done is actually concertina this down to 3 months by putting in much more resources in, but also doing things that they would normally do in a linear fashion in parallel to get to the same time. But we are not cutting corners as I understand it in this, and we feel confident in it. And the best bit is because we're doing that, we're getting to see what happens overseas, such as what happens in Norway, to get proper information. Because really what's happening overseas at the moment is what we call the phase 4 trial about the vaccine. We get to see what happens when it's actually put out, because really the early data that you've seen about these efficacy levels is very, very early. As a colleague of mine said, it's so early as far as that's concerned. It's really hard to make decisions about these community transmission and things like that. Issues that we know. The Pfizer vaccine is much harder to handle. It has to be kept at -70 and it's essentially dry ice. It comes in very large batches, which I won't go into. They come in multi-dose vials. And once it's defrosted, it has to be used within 5 days. So the logistics are massive, which is why really it's being done primarily through hospitals. And then you've got these hubs with the in-reach teams. The AstraZeneca is much easier. It's a much more normal vaccine, kept at temperatures much like the flus and any other vaccines, but it still comes in multi-dose vials of 8 to 10 doses per vials. Now there is variation because there's been, they sort of count for wastage, but they've been able to get more doses out of the vials than they thought they could. So it's actually been a positive thing in all this. Now, the big thing that you'll all be wondering is about safety. Right. Okay. So can I just say to you, safety appears to be very good, both on theoretical grounds and what we've seen so far. Now, certainly, let's talk about the Pfizer vaccine. The Pfizer vaccine has always been known to be a very reactive vaccine. Because of the way it works, it actually produces a really quite intense response. So it produces a very sore arm usually. It'll produce sometimes a fever and diarrhea. And so it produces, but that's what it's trying to do. It's producing a strong response to try and get your immune system going. There have been theoretical issues about two things that people have brought up. One is that because of they're essentially a type of DNA or genetic code, whether that can be incorporated into your cells long term and somehow affect your body in some way long term. Now, the experience with DNA vaccines over the last 22 decades has not shown any of that so far. And really, they look like very safe vaccines. So that doesn't appear to be an issue. The other thing is you've seen over the couple of days this issue about Norway, about the elderly and the deaths in Norway and also Germany. Look, we all know working in this area, we're talking about individuals who are extremely frail. And the question has come up whether this is just normal background deaths in that age group, which we would all understand for all of us who work in that area, but also the possibility that for that group, whether the stress of the reaction, such as the fever and the diarrhea, may have been critical factors in actually causing a cascade for those who are extremely vulnerable or near end of life. And so the question is going to be for the TGA, what indications, because their job is to come out, say whether it's approved, whether it's safe, what are the indications and contraindications. So we will get that probably quite soon. The AstraZeneca vaccine really doesn't appear to have too many issues with it. It's been technology that's been used before. The only thing that does come up with it, because it comes with a viral vector. So essentially they're using this chimpanzee adenovirus to come in. The theoretical thing with an adenovirus produces like a cold type thing for many people. You become immune to the adenovirus over time. So boosters may be problems in the future. So you may because your body will become immune to the actual adenovirus that the genetic material to printing stuff is actually being you're injected into. So you may become more immune. So say it's a 2-dose regime, but the 3rd and 4th doses may be less effective over time because your body will actually kill the adenovirus before it can actually get into your body. Now, there is one other thing you're going to hear about, and I'll be upfront with this, which is this issue which people go on about, is this called antibody-dependent enhancement. Now, essentially what that means, that is this phenomenon where if you get, theoretically, where you get development of immunity, which is suboptimal, the antibodies that don't work fully to neutralize a virus, what happens then is that the virus, your antibodies attach to it, but don't kill it off completely. But having the antibodies there may in fact actually allow it to get into your cells more easily and then theoretically enhance the ability of a still active virus to go into your cells. Now, that has been a theoretical issue with, as I understand it, SARS, which is obviously a related vaccine, and other viruses like dengue fever and things like that in the past. Now, this is something that people go on about. There has been, I've read a couple of papers about, there's no evidence of that at this stage. So the theory is that because if you have a suboptimal vaccination, that it may actually make it worse for you later. There is no evidence of that at this moment, but you will hear about this over time. The final thing is about variants. There are these variants that have come out, which is the UK and the South African, and now there's a Brazilian one and probably a Russian one, which all look more contagious in the fact that they've changed in some way to allow the virus to bind to the cells more easily and go in. At the moment, there's no evidence that any of the vaccines. Now, there's work at the moment. I attended something from the World Health Organization last week. They're looking at, this is urgent matter because they're looking at it. And one of the things is whether the vaccines still work. There is no evidence at this stage that the vaccines are a problem at this moment in time. The other good news is that over time, the mRNAs particularly can be recalibrated quite quickly to cover that. The final thing I'll say is that at this moment, Australia, the priorities were to base decision-making on what was known. And again, what is known is that they're good at stopping severe disease. There's the evidence in stopping community transmission and herd immunity and all those things are much less at the moment. So the decisions have been about that. That may change over time as we get more information. That's really important to know. The other thing is that there are other vaccines in the pipeline. There's 60 odd potential vaccines out there, some of which Australia's got contracts with, like the Novavax, for example, and Moderna. As they we get more evidence, it may be that Australia may change its tack in terms of the vaccines that come into play. Just couple of final things that I'd say is because of the difficulties of the Pfizer, that's why it's been run through these hubs. From my perspective, there are issues that are still, which I'm involved in with the target subgroups, so things like education and consent, which I think is important. And I think something that we probably got to progress that a little bit further, because we all understand the matters of consent with things like Zyprexa and those sort of things, which have been hot topics. But, we are talking about a vaccine which is relatively new, for which people may have questions about. We do need to have proper consent, even from substitute decision makers, to get the vaccine. And obviously there's these major logistical problems, which I hope I've given you some idea of, but I think we're still working those things out. Look, I hope that I've given you a bit of a cook's tour of some issues with the background to the vaccines and some of the thinking behind it. And also we may probably discuss some of the other issues like consent a little bit later, but I'll hand over to Libby.
Can I just say there's lots of questions coming through and people are going, wow, Chris, thank you so much. I think people will be playing it back. There was a lot of information. We will send around that fact sheet that Chris had up on the screen so that people can see it. So lots of questions coming in on the vaccinations. But Libby, ER.
Thanks, Chris, and thanks, Pat. That was a lot of information, and I have actually certainly learned something, so that's excellent. As Pat said, my area of expertise is employment and industrial relations, so I will be talking to you today about whether or not you can compel employees to have the COVID-19 vaccination if the government does not mandate it. There's also a question about volunteers, residents and their families. I do have some information about that from Anita Courtney, one of the other experts in our firm, but it may be that you have questions about that I may not be able to answer. So look, the question is, can you make the vaccination mandatory in the absence of either a federal or a state government issuing whatever it is that they need to issue, whether that's legislation or directions? I think from the outset, it's useful, I think, to go back through a little bit of the background of the flu vaccination, because I think it might also form a path forward. So look, you will all be familiar with the fact that a number of years ago, aged care grappled with the flu vaccination when we had a pretty horrific flu season. A few years ago, there was a lot of talk by the government about whether it would make flu vaccinations compulsory or whether it would just leave it to the employer. And what we know is ultimately you were required to do a number of things. It wasn't mandatory, but you had to make it available and do some education. So I'm not going to go into that, but I think it's going to be useful for the purpose of our discussion. So the pandemic brought with us a very different discussion and different and new risks. And we've obviously seen what's happened in aged care. And I also think that's relevant to ultimately what might happen and the answer to the question that's being posed. So what we also know is that in early May last year, the states and the territories had the directions issued that it was basically mandatory to have the flu injection in order to enter into residential aged care. We also know that during the second wave in Victoria, that dropped out of the directions, and I understand that that's also dropped out of the directions in Queensland. So that's really, I guess, just a very short version of what's happened with the flu vaccination. So no secret that from a legal point of view, the simplest and the easiest way to deal with this is that the government makes a decision. In the absence of the government mandating this, I think it's going to be difficult. And I guess then there is the question, and there was a question actually prior to this in my mind as to whether they would contemplate mandating it in residential aged care or home care as well, but I think Pat's given some really good information about that. So I think there's been quite a bit of press about this, particularly over the Christmas break, and it's pretty clear that it's coming because the vaccination is said to be a number of weeks off. And I think, unfortunately, for you guys in residential and home care, you're on the front line. You'll get it. You'll have to answer this question first. I do a lot of work in aged care, but I do work in other industries, and I guess they're going to sit back and see what happens to you guys, which, you know, given the environment that you already operate in, I think that's incredibly difficult. So if this is rolled out, I think if the government's not going to mandate it, it's going to come down to whether or not requiring an employee to have the vaccination is a reasonable and a lawful request. It's not like other reasonable and lawful requests. It's quite particular. It's going to require an employee to actually put something into their body. It's not like asking somebody to do their job or to tend to a resident or to perhaps have a police check. It's quite invasive, and obviously there's always risks that come with that. I'll leave those questions to Dr. Moy and not venture down that path. But I think employers are in a very difficult position if the government does not mandate it. You're likely to have to make a choice, and that choice will be either to mandate it yourself or to perhaps mandate it for some employees and not other employees, or perhaps just to do nothing and hope everybody has it, but otherwise don't do too much else about it. So look, and there's a few options within those sorts of parameters. I guess in my mind, there's a few questions there, and obviously based on your legal obligation. So one of the questions for my mind, and like I said, I don't have the answers to many of these. How can an employer maintain a safe workplace as you have an obligation under the workplace health and safety or the occupational health and safety legislation that applies to your workplace, if you know that there's a virus out there that if it gets into the workplace can make people sick and or die, and there's a vaccination available? That, I think, is a quandary for you. If an employee contracts COVID at the workplace, we know they can make a claim for workers' compensation. And what we also know is that WorkSafe can come onto the premises and perhaps prosecute you for not providing a safe workplace. I know I'm not helping here, but I will continue. So what do you do if somebody refuses to have a vaccination? Is it likely to lead to termination? Possibly, I would have thought so. I mean, some of your direct care workers, you won't be able to redeploy them. You won't be able to put them elsewhere. And we know that you've already got a shortage of workers. So what if somebody can't have a vaccination due to medical grounds? What are you going to do with them? If you make it mandatory, that's likely to give rise to a number of discrimination issues. Might also lead to you having to make sure that they wear full PPE, because if you've made the vaccination mandatory, you've recognised there's a safety risk, and then I guess it's a double-edged sword. You've got to address it if somebody can't actually have the vaccination. There's also the question about, well, what if somebody refuses and the rest don't? Do you have the right not to work with somebody who hasn't had the flu vaccination? And what does that mean for residents? I think there's lots and lots of questions, and as you can probably hear as we go through them, again, it's resolved if the government is going to make this mandated, rather than leave it up to every single workplace to decide what their policy will be. And in deciding what your policy will be, you know, there's a number of different options. Now, I don't have a great deal of case law for you. I am going to take you through a couple of cases because I think they're relevant and I think they provide some really positive information. There was a case handed down late last year, the case of Arnold and Good Start Learning. It was handed down in the Fair Work Commission in late November. What happened was a Victorian childcare centre brought in a vaccination policy whereby it was mandatory for childcare workers to have the flu vaccination. So it was not otherwise mandatory in childcare, and I think we can draw some correlations with the aged care industry. The policy said that if you had a medical issue, you didn't have to have it, but otherwise, unless that was the case, it was mandatory and it was a lawful and reasonable request. The applicant who filed the claim refused to have the vaccination. She did not raise any medical grounds. She simply refused to have it. They went through a process and ultimately her employment was terminated. So she made a claim for unfair dismissal. So the position of the employer was, well, we are in childcare. Some of these children are not old enough to be vaccinated. It poses a risk in this particular workplace, and therefore it's a lawful and reasonable direction. Unfortunately, she filed her claim a day late, and so it became a jurisdiction question. For those of you who are unlucky enough to be familiar with the Fair Work Commission, that's not quite a decision on the actual point. It's actually a decision on whether or not the Fair Work Commission will grant an additional period of time within which to file the claim. So just bear with me. It's some commentary which I think is very useful, and I'm just going to read some of it because it's actually quite positive. The Deputy President said this.
Libby, it's Pat. Can we get you to, are you going to be able to wrap up in about 5 minutes?
Yes.
Yeah, terrific. Thank you.
While I don't go as far as to say the applicant's case lacks merit, in my view, it is at least equally arguable that the respondent's policy requiring mandatory vaccination is lawful and reasonable in the context of its operations, which principally involve the care of children, including children who are too young to be vaccinated or unable to be vaccinated for a valid health reason. So there's some comments in that particular case which are very helpful if ultimately the government don't make this decision and you decide that you're going to make vaccinations mandatory at your workplace. There's also another decision. It was quite a while ago and prior to the pandemic. It's the decision in Black and Warwickshire Council. It said that if you have a policy and you have a committee, a OH&S committee that looks at these and updates things, and you decide that there's a risk and you ultimately make vaccinations mandatory, it is possible in certain industries that will be fine. It will not breach the occupational health and safety legislation. Of course, it would depend on the circumstances, but again, there's some very positive comments in that particular case, but it's not on point because we haven't had a pandemic before. So look, the decision could go either way. If ultimately you have to go it on your own and make COVID-19 vaccinations compulsory for employees. I don't ultimately have the answer, but I do think there's some positive case law out there. You will just have to decide what you're going to do. If you're going to do anything, in my view, you're going to have a policy. You're going to have to implement it. You're going to have to do some education and decide if everybody has to have a vaccination or not. Ultimately, you could just decide to have a policy encouraging everybody and making it available like you do now with the flu vaccination. Just briefly moving on, because I will wrap it up, Pat. I do think that you would be able to make it compulsory for visitors. I think it's extremely difficult to make it compulsory for residents and their families, mainly due to the rights that residents have under the Charter of Rights. I'm not going to take that any further, but the information I've got from Anita and certainly from her team is that under certain circumstances, particularly an outbreak, you may be able to require residents, but it will be difficult under the Charter. So look, just wrapping up, that's my view. I think it'll be difficult. There's some positive comments. If you're going to do it, decide what you're going to do, have a policy and do some education. Thanks, Pat.
Great. Thanks, Libby. That's terrific. And look, I just want to say again, our advocacy has been strong and clear on the fact that we want the state governments to actually make it a workplace requirement. That's the way that it needs to be done through the health orders. And we have also, about a week or so ago, we wrote to National Cabinet expressing that view as well. So we're very clearly on the record. We've been doing media around that. That, you know, as long as there are no issues as a result of Norway, which it doesn't sound like there are, then this has to go ahead, and that we need the states to do it. And as I said, the unions are seemingly supportive of that. So hopefully that will line up, and hopefully what will happen is that it will be made a workplace requirement. But we wanted to have Libby here today so that you could start to think about, we've learned through this whole process that you can't necessarily rely on the state government to do the things that would seem like they were obvious and sensible. So we've still got to wait to see what happens there. So thank you, and it gives us some food for thought and things to take into account if we find ourselves in that position. Now, Chris is doing a great job. He is motoring through the questions, but I am still going to do it a little bit the old-fashioned way, and go through and just make sure that everyone can see the answers that are coming up. And a lot of the questions are about the vaccinations, so I'll roll through them. People have asked the question about the CHSP, whether clients and workers in CHSP will be included, and whether people who are waiting for a package would be included. The Minister was certainly clear that home care was covered. I took that to be CHSP, but I will check that, and we will ask the question about people on the waiting list. But we will do that and come back to you. Some of this is now Chris's territory. Chris has typed in here, can an individual have the flu vaccination and the COVID vaccination at the same time? Chris?
Look, at the moment, there's actually a dispute about that. And overseas, generally, it's no at the moment. And the part of the reason is because we're talking about a new vaccine, and they want to actually be able to separate the side effects, so to monitor it. So it's unclear at the moment what the TGA will come up with. So we're waiting on that response. But that is one of the reasons why it is not being given together with the flu vax overseas, which is a pain, because that means we end up with having 3 shots this year. We have to give everybody, which is a monumental task for the population.
And that picks up your next question, where the question was, are there any contraindications between COVID and the flu vaccine? That's where we're saying not at this stage, but they're not being given together overseas. Frank has asked about retirement village residents and whether they'll be treated differently. Again, we didn't ask that specifically, but we will go back to government now and do it. And clearly we know that there are often people on the same campuses and coming into residential care. So we will ask that question and get an answer for you. The question that was who's getting what vaccine. So Group 1A, which is residential care workers and residents, Pfizer is the way the Minister expressed it. 1B, and Chris is saying it's a mix depending on the vaccines coming into Australia, but the way the Minister expressed it last week is 1B will be home care clients and staff. And in his view, that was going to be AstraZeneca, but take your point, Chris, that vaccines are coming in. That's what they know at the moment. There were a number of questions about whether the vaccination is safe for pregnant women. Chris?
This is unclear at the moment, and the advice is different across in different parts of the world. We'll have to see what the TGA, they're looking at. That's the sort of thing they're looking at. And that's their job. At the end of this, they're going to come out and say, this is what the evidence is. These are the groups where there's contraindication. This is where there may be risk, where the risk benefit may be worth it. And I'm not sure what they're going to come up with. But overseas, there is still this sort of borderline risk benefit thing for the giving the vaccine. There is no theoretical problem with it, as I understand it. But it is not totally clear at the moment. So I can't give you a clear answer.
And Chris, people raised, and I guess your answer is the same, they raised in other questions things about autoimmune type issues or other conditions like Guillain-Barré I saw, and you're basically saying that that's what the TGA has to look at?
Yeah, there's no evidence of Guillain-Barré so far. There's no reported cases of Guillain-Barré response, which is the classic. In terms of other autoimmune type conditions, I mean, obviously they're going to be looking for this, but again, nothing so far. We're in a great position to look at that. So we'll see what the stats look like at the moment. I think that the other one was that business that I was talking about, the autoimmune dependent enhanced sort of response. That is actually the sort of one which people have been watching out for, but again, no evidence of that at this moment, which is great.
Thank you. There's a really good question about the difficulty that Chris has raised and that I've raised about consent, information and consent. And the answer there is that both the AMA and ACSA is raising this as a major issue, and Chris has put in his response that he doesn't think they fully realise the critical ethical and legal requirements for informed consent. So that's something that we'll continue to be raising. There's a query regarding conversion by the older adults. Currently, some vaccines are ineffective in older people. Chris, you're saying no, they look good.
Look, I mean, that is reasonable, but they do appear to be effective in the age group at the moment. The problem is that the Pfizer is probably the one that's going to be more effective, I suspect, possibly. But the problem is it possibly puts people under more stress potentially, and that's the issue with the very, very frail or near end of life, and whether they're the right people to be giving the Pfizer vaccine to. Be very interesting what the TGA come up with. But their job is to do this independently of government. They are an independent organisation. That's really important to understand that, and hopefully, we'll get some clear advice about what to do that's workable.
And extending your comment earlier about children under 16, the question is this: so children are being targeted. If no children are being targeted, what's the risk for staff in aged care who may be infected by their children, and how does that work with unknown immunity duration?
Look, I can't talk about the immunity duration. All I can say is that, I'm talking offline to people who are saying hopefully we're going to get 2 or 3 years out of these vaccines, but I'm not saying that. I think at the very least, we're looking at least 9 to 12 months of the vaccine at the moment, which will get us out of a hole, and then we can look at the longer term plan. As far as the children, you're absolutely right. We don't know whether it can stop transmission. Hopefully we'll get data about it. Again, what I've said is that there's no evidence of it. It may, but there's no evidence of it at the moment. The initial data was purely about whether you got sick enough to actually go have a test. And they compared 2 groups and found that, Pfizer was much better at stopping you getting any sniffles or cough, so you didn't go get a test. The evidence of this transmission thing is much harder data. We're going to need this long-term information. It's going to take a while. So all we can do is make decisions on what we have. So at the moment, the main point of having the vaccinations, it would seem to me, even in aged care facilities, is number one, to hope that we protect both the residents, but also the staff, from getting sick and ending up in hospital, and hope that we're getting some benefit about reduction and it's spreading through. That's the hope bit at the moment.
Thank you. There's a good question that's come up a couple of times, which is about if all staff are being vaccinated on one day and they suffer symptoms, what will happen? They'll have to stay away or get COVID tested. So this is a question we don't know the answer to between us, Chris and I, but we're saying it's a good question, and we'll put that into consideration in terms of the logistics for government to be thinking about. There's a couple of questions, Chris, about long-term side effects. Do you want to make a comment about that?
Look, I don't, okay, I don't want to sound like I'm dodging this question. The bottom line, these particular vaccines haven't been around for a long time. There have been similar vaccines that have been around in the past, particularly the AstraZeneca, but also even the mRNA vaccines. They've had these DNA vaccines in the past, and they haven't produced long-term problems. People haven't turned into zombies long-term by changing genetic material or anything like that. So, I mean, all I can say is that there is no theoretical reasons why they would do that. But, they haven't been around for long enough. But would I feel safe about having one of these vaccines and look at the risk benefit? I would say that they look extremely safe, and we're very lucky to have them. And I'd be very happy to have any of those vaccines at the moment. So that's what I'd put to you. And I don't, we can't keep jumping at ghosts on this, because we are talking about, people go, oh, why are we putting the vaccines out quickly at the moment? And, why don't we wait for 3 years? Well, I tell you now, if we get a UK strain in here, or we get a South African strain, there ain't no controls that restrictions are going to stop it. So we have to get on with it. We have to start protecting people at the moment, because the risk is so high of that taking off. Queensland almost has dodged a bullet at the moment in terms of what happened there.
Sure. There's a couple of questions about people receiving the vaccination. Will they test positive for the virus? Should they be tested in a time period following the vaccination?
Not that I know of, because it's not, if you think of this is, what it does is it produces spike protein, and then you produce the antibodies. I don't know of it causing your test to become positive. I mean, basically it's usually the test is usually picking up mostly whole viruses, which are replicating, developing in your nose. And this vaccine isn't going to be doing that. So, when they do a swab, that's not how they do it. They would pick up the antibodies, but they won't pick up if they had an antibody test, but they're not the tests we're doing at the moment in Australia. We're doing these nose and throat tests at the moment.
We've got about 5 minutes left. What I'm going to try and do is go through the questions on the vaccinations. There are questions coming in for Libby. We can certainly stay on, or I can stay on for a little bit longer. Just checking with Chris and Libby, are you able to stay on for a little bit, 5 or 10 minutes longer, if we need to get through the questions? Terrific, thank you.
I can, Pat, but I've answered quite a few in types of answers. So
terrific. And if you want to, you can all see this in the Q&A. You can see what the answers are. So let's just flip over here and have a look at some of the others. The vaccinations are they free, and will they be free later? All I've been told at this stage is that the vaccinations are free. There's a question around compliance. I know that the Quality and Safety Commission is looking at that. They were on the teleconference the other day, and I think that's something that will be clearer as it goes through. The district nurses provide services to people in their own homes. What is the approach for these elderly consumers, please? If they're receiving home care, they will be covered, is what the Minister has said, and we're checking on other forms of cover for those people. But Chris, I don't know if you've got any other comment you want to make there, anything you're aware of? No, so just checking. If you're going in as CHSP, we're clarifying that. The flu vax isn't compulsory for home care. Will this change? The Minister has said that they're looking at what they need to do around the flu vax through the AHPPC, and advice will be coming on that. So that's another question we need to wait and see. I think we've well and truly covered whether the vaccination is going to be mandatory or a workplace requirement, and we'll come back to that with some of the questions that Libby's fielding now. Are the committees considering the effect of mass immunisations on single sites if the side effects can be quite strong? We could end up with a number of unwell staff and residents. I guess this is the same question we had before from Mark, and it's one that we will take up because we need to think about it in terms of the logistics. How will the regional and rural areas be able to manage the cold chain for Pfizer? Will this change the rollout timing or type? Now, the Minister was certainly aware of this issue, but Chris, I don't know whether you've got a view that, or anything you can say on that.
Sorry, I didn't quite catch what was.
The rural and regional areas, which are further away in terms of getting information.
Yeah, it's a big problem because these Pfizer vaccine comes in packs of trays of 197, with each one giving 6 shots, and that's the minimum sort of tray size. You've got to get it out there. There will have to be sort of these regional hubs which they've got to be setting up, but I can't tell you the exact thing, and whether it will be AstraZeneca over Pfizer in that situation is going to be the question.
But certainly it's something that I think that the Minister and the department had on their radar. There is concern about the impact of whether staff might leave when we've already got a shortage, and I think that's something that we know is a risk, and we'll cover that. So if the residents are all vaccinated, does it really matter if the staff are not, because the residents are still protected, aren't they? Chris, what would you say to that?
Look, what I've said is it doesn't. We don't know about it. So the reason why they're doing this is because they know about one, that they can protect both the staff and the residents, because they don't want the staff ending up in hospital and dying as well. That's the thing. So they want to protect that, but they're also hoping for the second, right? And they feel that, they're going to get essentially the biggest bang for buck in effect at the moment is there, because it's the highest risk population, highest risk, so they are hoping for that. That's all I can say. So it's just common sense that's why this is the group to really try and vaccinate, because of that.
And look, there's a couple of questions around the AHPPC advice and whether the flu vax mandated and whether the COVID vax is mandated. That's all being considered now. It will be state governments, and we are advocating strongly about that so that we do have a consistent approach. Just repeating, there's a couple of questions there. Home care is covered as 1B. There is a registration process that's going to be developed. I don't know the details of who's doing the rollout in regional areas, and we've just touched on that. That's probably something that still needs to be looked at. Comment here about in-reach or regional hubs. The Commonwealth is definitely rolling out an in-reach, but I will put in some of the comments that have been made here today about regional hubs, particularly for staff who are on days off or for some other reason weren't there for in-reach. Frank's asked a question about back office, head office staff. I don't know the answer to that, Frank. I will ask that question. Will in-reach services administering the COVID-19 vaccine supply associated equipment, or will this be the responsibility of the approved provider, sharps, disposal, etc.? Chris, I can ask that, but I don't know if you've got anything further on that.
The provision, sorry.
Of sharps, disposal, cleaning products?
Don't know. I mean, most of this, no, I honestly don't know that one. Actually,
no, and that we'll raise that and find out. Yes, we can try and get you a copy of the Q&A. What we'll do though is we'll try and get answers to the ones. We'll try and produce a document that's got the answers to the ones that are already answered, so that you've got those, and we'll come back to you on the ones that we need to go back. So we'll do a little bit of work and get something to you pretty quickly. But there are some that we have to go back to the government about. Yes, there will be information and FAQs coming out for consumers and staff besides the website. And what other questions have we got here? Yes, the maintenance of services in terms of what the effect is. This is really good feedback for us to be providing to the government about the concerns and filling out some of those in more detail. Chris, there's one here about managing adverse reactions. Do we know anything about monitoring and access to medical treatment if it is done in reach?
Well, I mean, normally it's still the monitoring for 15 minutes afterwards, but it's interesting because I've seen some of the advice overseas that you don't have to do that anymore, which I think is pretty gutsy. Certainly we should be having adrenaline around a place like we would for any vaccinations, particularly the Pfizer, because of the anaphylactic reactions that happen with those people with significant allergies. Those people with anaphylaxis will be contraindicated for the Pfizer. So if you've had that, you'll be out of it. Almost certainly. Those people with moderate allergies, we're going to have a discussion about, and that's going to be not a straightforward thing, I think.
Thanks, Chris. Look, in the few minutes that we've got left, and I know some people have dropped off, but there are a number of questions for Libby, and she's working her way through them. But just quickly, there's a question about whether anti-vax is a political view for the purposes of general protections claim, or where termination of employment is concerned.
Yeah, I don't think so. It will obviously depend on how they couch it, but how it's couched. But I highly doubt it. Although I have said in that response that I do think there's a different question about if it becomes a religious issue, if it's, you know, we have freedom of religion, and most of the legislation in each state and it federally has protections about religious views. But look, ultimately it depends on how it's put. And we do know that in the past there has been some religious exemptions. I think originally there was one for the no jab, no play in childcare, but ultimately that has also been removed. So look, it is possible. Will depend on how they couch it, but I doubt it. I doubt it will stop you from requiring them to be vaccinated, unless, of course, it's some sort of health issue / disability or medical reason.
And if we do have a policy that's not because the government's mandated it and individual organisations have policies, would it be considered a major workplace change that requires consultation with the workforce and the unions, Libby?
Yeah, the way I answered that was, look, it really depends on the clause in the enterprise agreement. Now, I'm just thinking about most of the standard clauses I see in my head. They are usually predicated on there being such workforce change so that people are losing their jobs or terms and conditions of employment. So it would really depend on the actual enterprise agreement. But possibly not when I think about the standard clause.
Okay.
I can't really answer it for each individual employer.
Another sort of question that's come through is, could, if staff are compelled to have it, could they refuse to care for residents who don't have the vaccine?
I don't think so. If they've had the vaccination and the resident hasn't, this might be for Dr. Moy, but I can't see there's any additional safety risk at the workplace. But I think the issue will be if the resident hasn't and the employee hasn't, and then, even then, there's other things you can do, because we have already seen during the pandemic that donning PPE and those sorts of things can also be an added protection. So if, for example, you decide not to implement a policy of mandatory vaccinations in the event that the government doesn't mandate it, it doesn't mean to say that you can't put other things in place. So if people don't have it, you might take the position that if they are not vaccinated, then they still have to wear certain PPE or take a certain additional precautions. So the policy would be fairly detailed and complex, I would have thought, to guard against any potential risk if somebody hasn't had the vaccination.
Thanks, Libby. Look, I'm really conscious of the time, and I want to thank Dr. Moy and Libby for both staying on for an additional 5 minutes. We've captured all of the questions. We will get those that have already got an answer, we'll get them out to you as quickly as we can. We'll follow up the ones that don't have answers and come back to you. Be assured we are working with government to get answers to the questions. We'll be supporting them and you through this process. We will continue our advocacy that we think that the best thing that could happen would be for it to be made a workplace requirement through the state health orders and probably with the flu vaccination. So we'll keep up on that. I know it's frustrating when you probably want information now. It's not here yet, it's coming, and the government's aware of how important it is. We'll keep the pressure up on them to do that. We'll keep working on this. So I hope you found it a useful webinar. I've certainly learned a lot today, and thanks to Chris and to Libby again. Remember, there is a recording of this because there is a lot of information that we rocketed through. We probably could have spent half a day, I suspect, but you will be able to get the recording, and we will also circulate that fabulous document that Chris put up that gives you a bit of a sense of both of all of the different vaccines that are there and what they do. So with that, I'm going to close the webinar. Thank everyone for their time. I hope you found it useful. It's going to be a hot topic, and we'll keep following it up, and we'll get those answers to you. I hope you enjoy the rest of your day, and I'll see you somewhere in the Zoom world soon. Bye, everyone.